chairpersons, my dear friend moderator, all my dear friends, colleagues, ladies and gentlemen. At the outset, I immensely thank my dear friend Maroof and Zubair for this kind invitation. I've been enjoying this great hospitality and food of Lahore from last 3 days. I think it is, I am very fortunate to have this, and I have been messaging my friends, once you must visit Lahore to enjoy the hospitality and the food. Really, I am thankful to you. I am so happy to be here. And with these few words, let me speak about the cholesteatoma matrix. Dear friends, I have an experience of nearly 27 years, and we do on an average every day 1 cholesteatoma case in my center. This is the 45 degrees, 0.5 mm peak. I can do this. Still, I am not pulling it out. I am trying to deliver this gel foam. Along with the gel foam, you can see that retraction pocket in the intercrural space has been delivered out. This is how you can do this in critical situation. The message here is never try to blindly pull that and give room for any recurrence. And again, the whole ossicular chain was intact in this case. So, and type 1 tympanoplasty has been done in this case.
So he was an oral surgeon. And then just a little bit of history. It was in the 1960s that the first dental implants were conducted, and the first osseointegrated implant was in 1977. Then the cradiofacial rehabilitation fixtures came in 79, and there have been lots of developments since then, but it was in 2009 that the magnetic transcutaneous implant was invented, such that the patients don't have a defect in their scalp, and you'll see what I mean in a minute. So I'm sure you're all aware of what bone conduction hearing is. It's when we use a tuning fork, you can hear it, and it goes directly to your cochlea. It's nothing new. It was a British chap in 1648 who was a philanthropist as well as a philosopher and a scientist, and he had built this institution because he wanted to educate the deaf and the mute. And I don't know whether you can see or not, but there is a instrument being played there, and that's a deaf person who's got his teeth onto the wooden arm of the instrument so that he could hear the music. So that was in 1648.
For D-class tumours, we do a similar approach to that I've explained, but in addition, as the illustration below indicates, we open the dura and deal with the intracranial component via a transjugular approach. So I sacrifice the jugular, get intracranial, and these I would involve a neurosurgeon. So to give you some idea, we reviewed 32 cases of C&D that had surgery over a prolonged period of time. The vast majority had normal facial motor function. 2 had grade 3, where I had to do some mobilization, or I had to resect tumor off the facial nerve.
The hypopharynx. So it's very important that you have a structured understanding of this. For all the trainees, it is essential that you start to do this in every clinic. This is the voice handicap index. I'm sure all of you are very familiar with this. Now, voice handicaps index is absolutely essential to know, and to some extent subjectively work out if the patient is improving. Now, let's look at this. So what happens when you do a video chymography or video stroboscopy? The difference between video stroboscopy and chymography is in video stroboscopy, we use light that switches on and switches off. So you see flashing light. I use video chymography, where you see there's a micro video system that switches on and off up to 300 times a second. And
now, it's very important to understand that basically spasmodic dysphonia, it is not ENT disease. It's basically a neurological disease. And the problem is in the brain, in the basal ganglion. So just imagine that the efferent signals are coming more to the thyroarytenoid muscles or to the abductors or adductor muscles. So that's where the problem is. So it is a part of a dystonia. And you must have seen many other type of dystonia in which they're moving their necks, moving their eyes, blepharospasms. So this is a focal dystonia of the larynx.
Summary of what's required. Although I'm not a good believer of guidelines, but these ones, I like them because it specifies what is needed. Most important thing is if you have a patient with hoarseness, you have to take a proper history and examination. And in examination, laryngoscopy is very important. And if you can't do laryngoscopy, you should refer these patients to people who can do a laryngoscopy.
If the cartilage is not available, it's a Revian case. Remove a small segment from the vomer bone, posterior part of the septum, but not from the upper part along cribriform plate, and make small openings with the help of 10 cc needle and just place it along the cartilage. It can serve your task. And stitch along the nasal bone, stitch along the anterior nasal spine. Most of the time we use just 2 millimeter drill machine burr and just to make a small opening here and have absolute stitching here. Because Gubbi says even though you have to use dental plates, you can apply on the septum. That micro plates can make the septum absolutely straight as you desire.
Now we come to conclusion. Teaching hospitals have defined criteria and a pivotal role in healthcare and medical education. Performance of teaching hospital cannot be optimized without a referral system. A hospital cannot and should not become a teaching hospital. A hospital cannot and should not become a teaching hospital by just starting an undergraduate college. A regulatory body should forge standardization at provincial level across the teaching hospitals. And that's it. Thank you very much. The take-home message is that every hospital is not a teaching hospital. And inshallah, we will discuss it at some other forum because it needs a lot of deliberations and discussions and understanding what is a teaching hospital. And most of the hospitals who claim to be teaching hospitals are not teaching hospitals. Thank you.
Thank you, Professor Khalid Ashrafi. Very good advice to all seniors. And that ends the session.